The treatment plan is the central organizing document of clinical work. It translates the diagnostic summary into a concrete, individualized roadmap, laying out exactly what the client is working on and what success looks like. A collaborative plan gives each session a specific direction and satisfies exact documentation constraints for reimbursement. Conversely, a vague boilerplate plan leaves counseling aimless. This plan operates as the middle link in the golden thread of documentation, acting as the structural spine of all clinical care. Here is how that thread connects. First, the clinical assessment identifies the client's raw problems and deficits. Second, the diagnostic summary takes those raw findings, contextualizes them, and organizes them by clinical priority. Third is the treatment plan itself, establishing the specific corrective goals to address those sorted issues. Finally, the progress notes and the discharge summary document the ongoing work and record the final outcome. If this documentation sequence breaks anywhere along the line, treatment loses direction. Care is no longer clinically defensible, and the underlying logic unravels. Maintaining this sequence requires client agency. The plan must be built with the client rather than for them to ensure they hold genuine personal investment in reaching the goals. Developing the plan as a shared architectural map keeps the focus on a collaborative recovery process, preventing the work from becoming mere clerical hurdles. Treatment planning begins by taking the sweeping findings from the initial assessment and distilling them into a focused, prioritized problem list. Not every issue can be addressed at once. Attempting to tackle all assessed problems simultaneously undermines treatment effectiveness and often overwhelms the client. We focus the work by defining problem statements. This means extracting the precise clinical language directly from the assessment, distilling pages of notes into specific issues like daily alcohol use with tolerance or untreated depressive symptoms. The counselor and client order this list based on 3 strict criteria: clinical severity, immediate safety, and the client's own stated priorities. Immediate safety and physical health issues take absolute clinical precedence. They form a non-negotiable baseline for care. However, the clinician must balance this safety mandate with the client's perceived primary threats. A client facing immediate eviction will care far more about housing stability than their drinking behavior. If a plan ignores stated priorities and only lists what the counselor thinks matters, it produces superficial compliance at best and complete disengagement at worst. The counselor must collaboratively negotiate this reality, addressing external fears like losing housing, while maintaining clear visibility on treating the underlying substance use disorder. Problem prioritization is the exact mechanism that aligns the counselor's clinical mandate with the client's emotional reality. A common and critical professional failure in charting is conflating the structural roles of goals, objectives, and interventions. Goals are broad, aspirational outcomes. They represent the client's ultimate destination and their long-term vision for overall recovery. Because they are long-term and aspirational, goals are usually framed utilizing the client's specific vocabulary, such as establish stable housing or improve family relationships. Objectives, by contrast, are the concrete, measurable, and time-bound steps required to advance the client toward a single goal. Where a goal is broad, an objective possesses chart-verifiable granularity. Anyone reading the record must determine exactly whether it was met. Structurally, a plan requires multiple distinct objectives. A single goal depends on the specific, sequential steps to be realized. Finally, interventions are the specific actions, therapeutic techniques, and systemic referrals that the counselor will execute. While the client owns the goals and objectives, interventions are strictly provider-owned. They are the programmatic support structures enabling the client to climb those steps. Examples of interventions include weekly cognitive behavioral therapy focused on craving management, or formal referrals to a recovery housing program. Writing a plan loaded with aspirational goals but lacking defined, measurable steps and stated provider actions constitutes a critical documentation error. Cleanly separating what the client wants, how they will measurably get there, and what the clinician will do creates the engine of clinical progress. A finalized plan must be calibrated to the client's clinical reality, starting with their assessed ASAM level of care. The intensity of the interventions must match the setting. The structural requirements for an outpatient client differ from those required for a client residing in a high-intensity facility. Second, The assigned objectives must match the client's precise current stage of change. Assigning action-oriented abstinence objectives to a pre-contemplative or deeply ambivalent client typically results in resistance and disengagement. For early-stage clients, objectives focus on building engagement, raising awareness, and fostering internal motivation, rather than demanding immediate behavioral cessation. To counter the demoralization caused by a purely deficit-focused approach, the clinician must also employ strengths-based planning. Integrating a client's existing resources, familial support, stable employment, or past periods of abstinence directly increases their self-efficacy. This also mandates the incorporation of the client's cultural context, spiritual practices, and specific family obligations. A standardized plan that ignores a client's cultural understanding of recovery will lack relevance, and the client will not embrace it. Matching the plan to the client's precise clinical, motivational, and cultural reality is what transforms it from an abstract requirement into an actionable tool. The definitive hallmark of a functional and legally defensible treatment objective is strict measurability. We achieve this by using the SMART framework, ensuring every objective is specific, measurable, achievable, relevant, and time-bound. A weak objective, like working on coping skills, lacks a time frame and specific metrics. Without measurability, it cannot support real clinical progress. A strong SMART objective is concrete. Identify 3 relapse triggers and demonstrate a coping strategy within 4 weeks. It provides exact behavioral evidence. These highly measurable objectives protect both the client and the counselor by creating an undeniable visual record of progress in the chart. The required signatures on this document are not a mere administrative formality. They stand as clinical proof of genuine collaboration, consent, and HIPAA compliance. A completed treatment plan is a living document. It is not a static form completed at intake and forgotten. Because circumstances shift, the plan requires scheduled revision. Relapses, acute crises, major life shifts, or the achievement of a goal are specific clinical triggers that necessitate an update. A treatment plan that remains unrevised over long periods suggests that treatment has stopped responding to the client's changing needs. Consistent review maintains the structural integrity of the clinical thread, keeping care responsive from the very first intake clear through to the final discharge summary. When objectives are ruthlessly measurable and constantly updated, the treatment plan ensures accountability, making successful recovery visible and undeniable.